A 48-year-old man presented in November 2009 with decreased visual acuity, painful ocular movements, photophobia, and inferotemporal visual distortion. This was associated with mild ataxia and a 9-day history of a severe dull frontal headache, not worsened by the Valsalva maneuver. He had no past ocular history, and his medical history consisted of sciatica and psoriasis. Ocular examination revealed decreased visual acuity of 6/24 OD and 6/6 OS. Dilated fundus examination revealed an isolated finding of bilateral optic disc swelling, right more than the left, with associated splinter hemorrhages on the right. There was no evidence of restriction in ocular motility, such as 6-nerve palsy, which is a known false localizing sign for raised intracranial pressure, nor was there any other cranial nerve palsy identified. Reliable Humphrey visual field tests showed bilateral diffuse field loss. Following admission under the medical team for presumed raised intracranial pressure B blocker, where it commenced to relieve the headache, and radiological and hematological tests were performed. Chest X-ray and computed tomography were inconclusive. Magnetic resonance imaging of the head and orbits showed only nonspecific changes that did not appear to be of clinical significance. Ventricles, basal cisterns, and sulci were normal and symmetrical. Initial blood tests, including autoantibodies and syphilis, serology were also negative. On review 2 days later, his visual acuity was further decreased to 6/24 OD and 6/36 OS. Ishihara testing revealed a significant decrease in color vision in 4/14 OD and 3/14 OS. Intravenous high-dose methylprednisolone was initiated 1 gram daily for 3 days, followed by oral prednisolone 40 mg daily, tapered by 5 mg weekly. A lumbar puncture was performed, which revealed a normal opening pressure, helping to exclude papilledema and the presence of findings of bilateral optic nerve swelling. Further analysis of the cerebrospinal fluid found white blood cells and glucose levels to be within normal limits, and there is no evidence of microorganisms microscopy. Red blood cell count was slightly elevated, but in the absence of intracranial hemorrhage on cranial imaging, it is likely that this was secondary to traumatic tap. Further blood results revealed a positive result for B. Bergdorferi by Lyme enzyme-linked immunosorbent assay and Western blot serology. The patient had no recollection of any recent tick bites, but had sustained bites previously. Therefore, the diagnosis of Lyme disease was made in the absence of erythema migrans, because there was a history of exposure to an endemic area, involvement of at least one organ system, and a positive result from the laboratory. The prognosis was Lyme disease.